Dear colleagues, good afternoon from Tehran, Iran. First, I would like to thank Dr. Ben and the FUE Global World Congress Organizing Committee for their kind invitation. I was looking forward to join you in person. However, due to the ongoing war and the resulting travel restriction, I was unfortunately unable to attend. It's a privilege to share this presentation with you, and I hope to find it useful, and I look forward to seeing you all in person in the near future. I have no conflict of interest in this issue. Let's start with these two patients of mine. At first glance, they look very similar. Both are women with frontal thinning and widening of central part. In daily practice, many of us immediately think of female pattern hair loss. And honestly, most of the time, we would be right, but not always. One of these cases has female pattern hair loss, the other has frontal fibrosing alopecia. This is where the challenge begins, because FFA is no longer just the disease of receding frontal hairline. We now recognize diffuse and androgenetic alopecia-like presentation that can closely mimic female pattern hair loss, especially in early stages. The consequences of missing that diagnosis are important. One condition is characterized by follicular miniaturization, while the other may lead to permanent follicular loss. We say if one hair goes, it went, then we should be careful. So when a woman presents with frontal thinning, the question is not simply how severe is the disease. The real question is what is causing it. Over the next few minutes, I will discuss the clinical and trichoscopic clues that help us distinguish female pattern hair loss from early frontal fibrosing alopecia, and why this distinction remains one of the most relevant diagnostic challenges in the women hair disorder. Let us begin with female pattern hair loss. Female pattern hair loss is the most common cause of hair thinning in women. Clinically, it is characterized by progressive reduction of hair density over the central scalp, often with the preservation of frontal hairline. Patients typically present with widening of the central part and diffuse thinning over the crown. Trichoscopically, the hallmark feature is hair shaft diameter variability, reflecting follicular miniaturization. We commonly observe an increased proportion of thin and vellus hair variation in shaft caliber exceeding 20%, and an increased number of single follicular hair. Yellow dots and prefollicular pigmentation may also be present. Importantly, despite the reduction in hair density, follicular openings are preserved. This is a very important point because the follicles remain present, although miniaturized. Now let us consider frontal fibrosing alopecia. Frontal fibrosing alopecia, that 20 years ago it wasn't that prevalent, but these days we have a lot of cases. It is primary lymphocytic cicatricial alopecia and currently regarded as a clinical variant of lichen planopilaris, although classically associated with recession of the frontal hairline and eyebrow loss. We now recognize much broader spectrum of presentation you can see in these cases. Some patients develop diffuse thinning involving the frontal central scarp before obvious hairline recessions becomes apparent. In some cases, the clinical picture may closely mimic female pattern hair loss. You can see in the left picture, but in the right you can see a lot of erythema that it is a clue. One of the most important findings in frontal fibrosing alopecia is the loss of follicular opening. Unlike female pattern hair loss, follicles are miniaturized but preserved. Frontal fibrosing alopecia leads to permanent follicular destruction. Additional trichoscopic features include prefollicular erythema, prefollicular scaling, isolated lonely hairs at the frontal hairline, and absence of vellus hair in affected areas. Eyebrows involvement, even when subtle, should also raise suspicion. We should pay attention to the eyebrow of our patient, and in eyebrow, trichoscopic of eyebrow in frontal fibrosing alopecia, we can see the decreased number of eyebrows, and we can see that each eyebrow grows in different direction. In female pattern hair loss, miniaturization tends to follow a pattern distribution. In frontal fibrosing alopecia, change may appear patchy or disappropriately involve the frontal scalp and the hairline. Let us return to our two patients. If we focus only on the pattern of hair thinning, both patients may appear nearly identical. However, careful examination reveals clinical differences. The patient with female pattern hair loss demonstrates diameter variability and numerous miniaturized hair. The patient with frontal fibrosing alopecia shows prefollicular inflammation, reduction of absence of vellus hair, and early loss of follicular opening. This finding fundamentally will alter the management. For female pattern hair loss, treatment strategies focus on promoting hair growth, we will start the treatment with minoxidil and, if needed, anti-androgen, but in FAPD, anti-inflammatory treatment is required, like steroid, hydroxychloroquine, and minoxidil. Then diagnosis matters because wrong diagnosis will lead to wrong therapeutic paths. Our practical approach generally in a woman with frontal thinning should be trichoscopy, check if the inflammatory is present or absent, miniaturization is present or absent. What about loss of follicular ostia? In uncertain cases, we should perform a biopsy. Then we can recognize if it is FPHL, FFA, FAPD, or even other overlap of two of them. What will be the future? The future will be the better characterization of overlap syndrome with AI-assisted trichoscopy, quantitative image analysis, earlier recognition of inflammatory signature, and molecular biomarkers. At the end, we should not forget that fibrosing alopecia in a pattern distribution is a form of scarring alopecia with pattern hair loss, similar to androgenetic alopecia, but with trichoscopic and histopathologic sign of both lichen planopilaris and androgenetic alopecia in the sign biopsy specimen. It is a new entity of pattern hair loss which can be easily missed if trichoscopic examination is not performed. A histopathological examination should always be performed from the trichoscopy guided prepilar cast area. Hair transplantation should not be performed in these cases due to the potential risk of cauterization and loss of transplanted hair. The future will lie in earlier and more objective diagnosis. Thank you for your time and your attention.